اوكي. طيب انا في الاول خالص انا جاست ان انا هتكلم على الايفكت اوف controlled stimulation on the endometrium. There is a difference between stimulated endometrium or natural or estrogen prepared endometrium. We have to know that there is an effect of controlled ovarian stimulation on the endometrium in the form of decreased endometrial and subendometrial blood flow. This is proved by 3D powered Doppler. The histologically proven advancement of endometrial maturation and disruption in the transcriptional activity of the genes involved in receptivity. So it seems that the controlled ovarian stimulation may have an impact or may have an untoward impact on the endometrium itself. This may be in the form of asynchronization with the embryos transferred at that time. It's just a reminding point about the effect of controlled ovarian stimulation on the endometrium. One point is if I'll talk about the indications, here are the indications for oocyte freezing, but this is not our main issue. We have social freezing, we have clinical oocyte freezing, we have oocyte donation, but this is not the main issue. The main point or the main indications for freeze all embryos, the first point is the PGT-A, genetic testing for the embryos. With genetic testing of the embryos, we have either to do the genetic testing on day 5 and do fresh transfer early in the morning of day 6, and this one way. But in conclusion, it's better to do day 5 testing of the embryos, freeze the embryos on day 5, then do defrosting the embryos and transfer the embryos in a subsequent cycle. Actually, the fresh transfer, if you will do testing on day 5, you have to wait to day 6 to do the fresh embryo transfer. And of course, if you do fresh embryo transfer of the genetically tested embryos on day 5, the pregnancy rate will be significantly lower because there will be impaired implantation because of the endometrial asynchrony. So the best way to go is to do genetic testing of the embryos on day 5, freezing on day 5, waiting for the results then you will do the transfer later on. Actually, from this slide, you will find that there is a difference between the frozen and the fresh transfer with the significantly higher cumulative pregnancy rate and live birth rate with the frozen if compared with the fresh embryo transfer. I know that there are some centers that they have the facility to do testing of the embryos and transfer even in the same day at night or on the second day, but actually the take-home message that it's better to vitrify, it's better to freeze the embryos and transfer it in a subsequent cycle. This is another study of the ongoing pregnancy rate of the frozen versus the fresh embryos. Here we have the 80% pregnancy rate versus 61 in the frozen versus the fresh embryo transfer. Okay, so many studies support the recommendation of the American Society, the ASRM, to freeze all for the PGT-A and transfer in the next cycle, just only to minimize the ovarian hyperstimulation, just only to decrease the possibility of endometrial asynchrony. The second point, or the second indication to freeze all embryos, is the try to avoid ovarian hyperstimulation. OHSS, this is a nightmare, and all of us know that OHSS, this is a big problem and very serious, life-threatening problem. So it goes without saying that all the people nowadays should freeze all embryos. If you have a high number of oocytes retrieved, you have to fertilize the embryos, follow the embryos to day 5, freeze the embryos, and control the ovarian stimulation. Then either the next cycle or the cycle after, you can do frozen embryo transfer. Actually, you will have a higher pregnancy rate, but the most important is the safety of the patient, that you will avoid completely, almost completely, the ovarian hyperstimulation syndrome. This is a large randomized controlled trial performed in the polycystic ovary patient of a big number of cases, confirmed that the frequency of OHSS was significantly lower with the freeze all, and subsequently the frozen embryo transfer. The incidence in the frozen embryo transfer is very low compared to the fresh embryo transfer. So it's very important for us to do freeze all for all the patients of polycystic ovary to avoid ovarian hyperstimulation syndrome. So this is one of the main indications, to freeze all the embryos to avoid an ovarian hyperstimulation syndrome. Of course, you will have also a higher pregnancy rate with the frozen embryos if compared with those people they try to do fresh embryo transfer. The third point for indication, or the third indication for the freeze all, is those patients having elevated progesterone level in the late follicular phase. Actually, Dr. Yacoub said that they don't practice this point. They don't practice the policy of freezing the embryos in the cycles where they have a high progesterone level in the late follicular phase. But there are many studies showing that if you have a progesterone more than 1.2 up to maximum 1.5, it may have a negative impact on implantation by impairing endometrial receptivity. Okay. Another point, does this elevated progesterone level had an impact on the oocyte quality and in turn the embryo quality? Actually, this is a debatable point, but if we'll go to the final conclusion that there is no evidence that high progesterone level may affect the oocyte and in turn the embryo quality. It has been generally accepted there is no negative impact of elevated progesterone on the oocyte quality and ongoing pregnancy rate in the recipients of the donated oocytes. And many studies in the donated program, in the oocyte donation program, showing that even if you have a high progesterone level in the late follicular phase, it has no effect on the oocyte and the embryo quality and does not impair or affect the pregnancy rate. Another indication for freeze-all of the embryos are the problems or the lesions or pathologies of the uterus, starting from the endometrial polypi, from the adenomyosis and hydrosalpinx. As Dr. Yacoub mentioned, the point of adenomyosis and the hydrosalpinx, but we'll just comment on the endometrial polypi. In the past, the appearance of endometrial pathology or endometrial polypi during stimulation, whether a big single polyp or multiple polypi, the protocol in the past that we cancel the fresh embryo transfer or even cancel the whole cycle and repeat it again after doing hysteroscopy. But nowadays we have different strategies that could be used in cases of having this ovarian polyps, where we can do oocyte aspiration with hysteroscopy in the same sitting, and then freezing all the embryos for a subsequent transfer. And I think this is a very smart way to go for the big endometrial prophylaxis. If you have a minute or a small endometrial prophylaxis, I think it has no effect about the pregnancy rate. But if you have a big one or multiple endometrial polypi, I think it's much better to do oocyte aspiration and hysteroscopy at the same setting, and then later transfer in a subsequent cycle. The second point is the second uterine pathology is the adenomyosis. Actually, this adenomyosis problem is not quite clear how to deal, how to do. Is it beneficial to aspirate the oocyte, freeze the embryos, and then you will go for the depot agonist from 3 to 6 months. It may have a good impact on the circulation. It may have a good impact on the endometrium. And then you will, after 3 to 6 months for the depot preparation of the agonist, you will start your embryo transfer after that. There are some studies regarding the effect or the impact of adenomyosis on pregnancy. And if you look for this study, they showed a non-significant increase in the pregnancy rate if you treat those patients with the agonist protocol for 3 to 6 months. Then you will start to do frozen embryo transfer. The third pathology related to the uterus and the tubes is the HYDROSALPINX. If you have fluid collected in the tubes and accidentally you didn't discover it, but I think this is somewhat difficult not to see the HYDROSALPINX before stimulation, but anyhow you can also do the same as with the problem of the endometrial polypi. I mean, you can do oocyte aspiration, and you may do a laparoscopy, or if you have the tools for hysteroscopic occlusion of the tube, you can do it and freeze all the embryos and transfer in a later cycle. So these are the 3 different situations or 3 different pathologies in the uterus, which is the endometrial polyp, adenomyosis, and HYDROSALPINX. If you'll go for a different entity that necessitate freeze all of the embryos, are those patients that having slow embryo development. In some of those patients that you may reach to day 5 and the endometrium and the patient is ready for fresh embryo transfer, but you didn't have any of the embryos present, showing typical the expanded pluses. In these cases, it's much preferred not to do transfer of these slowly developed embryos, and you will freeze them and transfer in a later cycle after thawing them 1 day early. Some people do transfer for these slow embryos on day 6, fresh transfer on day 6. But actually here you will lose the synchronization between the stage of the embryo maturation and the endometrial receptivity. And this will significantly decrease the pregnancy rate with the fresh transfer. So if you have slowly developing embryos, it's highly preferred and highly recommended not to do fresh embryo transfer even on day 6, and it's much better to freeze these embryos and transfer in a later cycle. If you do a fresh embryo transfer, will be slow maturation of the embryos, and embryos will not reach the +6 on day 6. Consequently, transfer will be delayed, because if you will go for fresh transfer on day 6, you will have a significantly lower lower pregnancy rate with the fresh embryo transfer. Last point or last indication for freeze-all of the embryos is the random start of ovarian stimulation. Random start of ovarian stimulation, I mean, all of us know that the stimulation usually we do it, we start the HMG or direct FSH early in the early follicular phase, either on day 2 or day 3. And we'll continue, and most of the protocols nowadays use the antagonist protocol. But actually, there are a lot of studies that you can start at any time, either early follicular phase or mid follicular phase or late follicular phase, early luteal or mid luteal phase. And one of the examples that we use it, the random start, is the poor responder patient where we do 2 stimulation waves in the same menstrual cycle. I know that some people say that you do stimulation early in the follicular phase and then you will wait for 5 or 6 days and do another cycle, another wave of stimulation. Some people may consider that the second wave is another follicular stimulation because you have withdrawal bleeding in some of those patients. But anyhow, you can do this double stimulation or do stim protocol as Ubaldi described it, and those group of Shanghai also described in different way. But anyhow, you can start your stimulation early follicular, and then you will aspirate the oocyte. Then after maybe from 2 to 5 or 6 days, we will do another wave of stimulation and collect the oocytes from the first wave, collect the oocytes from the second wave, fertilize all these oocytes, freeze all the oocytes, and then you will wait for menstruation, and you will start your frozen embryo transfer with estrogen progesterone preparation of the endometrium. Actually, if you do that, you may increase the number of the embryos available for transfer, and you may increase the pregnancy rate, especially in poor responders. The random start could be used also in those patients having malignancy, cancer patients who were programmed for cancer chemotherapy. They don't wait for enough time to start the cancer chemotherapy. Here, you can start stimulation of those patients at any time, provided that you don't have a mature follicle, and do stimulation, collecting the oocytes, and do either oocyte freezing or the embryo freezing, depends on whether the patient is married or not married, according to the social status of the patient. The last debatable point is the should we freeze all cases of endometriosis? There are some studies saying that freezing embryos of the endometriosis patient and transfer later on in third cycles may increase the pregnancy rate. Here we know that the clinical pregnancy rate with the frozen cycle is about 43% compared to 29%, this one of the studies, and the cumulative pregnancy rate with the frozen embryos 34 versus 17.8 in the fresh embryo transfer. There is another paper for the advanced endometriosis, and those people from China reported higher pregnancy rate if you freeze all embryos in the advanced stages of endometriosis because of the impact of endometriosis or advanced endometriosis on the endometrium in those patients. I think this is the main points that I have to mention, which is the different indications of freeze-all protocol. Thank you for your attention.